Welcome to Trio Maryland's August Zoom meeting, and it's really great to see everyone. Today's topic is immunosuppression and solid organ transplant and its infectious complications. And it'll teach you how to keep yourself safe. And we're so glad that you could join us this morning. In September, we're going to have a topic a little bit different, the VCA transplant, and it stands for vascularized composite allotransplantation, which means hands, face, penis, uterine transplant. And this is going to be one heck of an interesting topic.
Good morning. Today's guest speaker is Dr. Seema Steinke. Dr. Seema is a clinical assistant professor in the Division of Infectious Diseases at University of Pittsburgh Medical Center. She is also telemedicine faculty for ID Connect. Prior to moving to Colorado, along with her military husband and joining UPMC, she held a joint appointment for 6 years as assistant professor in the School of Medicine and in the School of Nursing at Johns Hopkins University. Her clinical focus includes transplant and oncology, infectious diseases, providing infectious disease care for oncology patients, as well as solid organ and bone marrow transplant recipients, and providing telemedicine care to various patient populations across the country. Her interests include multi-drug resistant gram-negative infections, transplant infectious diseases, oncology infectious diseases, antimicrobial stewardship in the immunocompromised patient population, and telemedicine care for transplant patients. I think we're pretty sure that she's a pretty smart cookie. We're very fortunate to have Dr. Seema address the Trio Maryland community once again. Dr. Seema is one of our personal favorites, and we're glad to have her back. Thank you for presenting to our group, Dr. Seema. Welcome, and I now turn the program over to you.
Thank you, and thank you for having me this morning. I am so glad to see the turnout. I think this is wonderful. All right, so my talk today is immunosuppression in solid organ transplant and its infectious complications. So we're going to talk about the net state of immunosuppression, what this is, how it's measured, and why it matters. We're going to discuss the overview of the immune system and explain the effects of various immunosuppressive drugs on the immune system and how that impacts infection development. And then we're going to list and briefly discuss commonly encountered infections after transplant. So let's talk a little bit about the background here. So solid organ transplantation has increased throughout the world since the first human kidney transplant in 1954. This was a living donor transplanted kidney performed between two 23-year-old identical twins, and this gentleman actually survived 56 years with his transplanted kidney due to medical advancements in immunosuppression and a technology to help preserve his organ. Medicine as a field has improved our ability to suppress the immune system and have longer organ survival. As a result, infection and cancer have actually become the primary barriers to survival after organ transplantation. And the prevention of infection is vital to secure excellent outcomes. So let's discuss some key items to remember. So there are sources for infectious complications, and those include community-acquired, reactivation of latent infections, and I will go into what that means briefly in just a few minutes, donor-derived infections, and nosocomial infections, or in other words, hospital-acquired infections. The inflammatory response in an immunosuppressed individual can be muted, and altered anatomy following transplantation may change physical findings associated with an infection. So those combined may make it more challenging for us to identify infection when it's present. Immunosuppressive drug levels provide a crude measurement of how immunosuppressed an individual is, in other words, this net state of immunosuppression. Patients are often more or less immunosuppressed than anticipated, and in fact, some drug regimens have side effects that mimic infection. So let's talk about what this net state of immunosuppression is. This is a conceptual assessment of the factors contributing to the risk of infection in an immunosuppressed individual. So this includes the type, dose, duration, and temporal sequence of immunosuppressive therapies. This includes underlying diseases and comorbid conditions. It also includes the presence of devices that are invasive, like a catheter for dialysis, for example, or a urinary catheter, or a surgical drain, or a ventricular assist device. This also includes other host factors that affect immune function, so neutropenia, or in other words, having a low white blood cell count, hypogammaglobulinemia, or otherwise also considering low antibody levels, or metabolic problems. And then also we take into account simultaneous infection with immunomodulating viruses. In other words, viruses that can also affect the immune system, making it more suppressed. And these viruses can include ones like CMV, EBV, hepatitis C, HIV, hepatitis B, and so forth. And we will touch upon some of these viruses as we go on through this talk. So the sum of congenital, or things that you've been born with, acquired, metabolic, operative, and transplant-related factors is a patient's net state of immunosuppression. So this is basically a sum of these entities, and that tells us as providers how immunosuppressed a patient is. There are multiple factors that are generally present in one individual at any given time. And we can roughly measure the net state of immunosuppression by looking at a patient's white blood cell count, immunosuppression drug levels, and noting the frequency and severity of common infections that may be arising. There are a variety of blood tests that are being developed to better measure this concept in order to better understand one's risk for infectious complications. But these tests are not yet available for practice in widespread use. So we don't have these tests yet available for us to make these determinations in a more concrete manner. So we still kind of use a very abstract way to understand how immunosuppressed an individual is. So let's briefly talk about the immune system. And I'm going to try and explain a very, very complex system into a very simplified format so that we can understand the rest of the talk going forward. So the immune system overview is your body's defense against infections. It's cells and organs that work together to protect the body against invaders and abnormal cells. And when the immune system is weak, germs and other abnormal cells in the body can more easily cause infection and other diseases. So this is a very good picture, in my opinion, of what the immune system contains or consists of. So we have this first box on the far left, physical and physiological barriers. So this talks about skin and mucous membranes, body temperature, these big global things that help protect our body against infection. Mucous membranes are the linings of the openings of our body. So for example, the inside of our mouth or the inside of our nose. Then we have the innate arm of the immune system, and this includes all different types of white blood cells, neutrophils, basophils, macrophages, dendritic cells, etc. And I say here that this is a rapid response arm because this arm of the immune system goes into effect very quickly. And then we have the adaptive immunity arm, which is a slow response arm. And this consists of cells called T cells and B cells. And this is how antibodies are produced. Hence, it is a slower responding arm to your immune system. But I'm going to go into a little bit more detail than this. But I'm going to start with the organs. So your skin is your first line of defense, and that includes your mucous membranes, as I mentioned, the lining of your mouth or your nose, etc. Then we have our bone marrow, which is where white blood cells first develop. And then we have our lymph organs, which is where mature white blood cells live and await instruction to go and fight invaders or abnormal cells. So the lymph organs include your spleen, lymph nodes, thymus, appendix, tonsils and adenoids, and patches of tissue in your small intestine called Peyer's patches. So that, again, is that first left side column there that discusses the main big scope kind of organs involved in your immune system. So let's go to a little bit of a microscopic level. Let's talk about the innate arm, or that rapid response arm of the immune system. So this is where a whole bunch of white blood cells live. And I'm going to talk about two specific white blood cells that are quite important. One is called a dendritic cell, which lives in your skin and your mucous membranes and helps protect the openings of your body. These cells function to capture and carry invaders to your lymph nodes and spleen for destruction. And then we have macrophages, which is another type of white blood cell. And macrophage literally means big eater. It's Latin for big eater. So these cells capture and carry invaders to your lymph nodes and spleen to do the same thing that dendritic cells are doing, to eat these cells and destroy them. So these above cells are known as scavenger cells. So they eat foreign invaders, break them apart, and then display pieces of the germs on their surfaces. The pieces that they display on their surface are called antigens. The body then produces antibodies to these antigens, which allow for memory of the antigen in the future. These cells also produce chemicals which tell other immune cells to go into action and do their job to help fight the invader. So let's now move over to the slow response arm, or the adaptive immunity arm. So as I mentioned earlier, the adaptive arm has two types of cells that are predominant: T cells and B cells. There's three different types of T cells that exist: helpers, killers, and suppressors. So once these pieces of germs called antigens are presented on macrophage surfaces, helper T cells, also known as CD4 cells, see the antigen and then coordinate and direct the activity of other types of immune cells, telling them, go fight this particular invader, find this invader and go fight it. And then you have killer T cells, also called CD8 cells, which directly attack and destroy the body cells that are infected by these germs. And it also fights abnormal cells that may become cancerous. So our immune system is constantly trying to battle invaders and abnormal cells to help protect us from both infection and cancer at all times. Suppressor T cells, also a type of CD8 cell, help to call off the attack. So once your invader has been conquered, these CD8 cells, suppressor T cells, call off the attack by your immune system and tell it, we've done our job, we've won the war. Now let's talk about the B cells of the adaptive arm. So B cells and antibodies go hand in hand. B cells help to produce antibodies, and antibodies are called immunoglobulins. Antibodies attach to the antigens, or the pieces of germs that are being presented on macrophages, and they attach to them like two perfectly fitting puzzle pieces. So when you're exposed to a germ for the first time, your body produces antibodies over weeks to months to help fight it. This is similar to a vaccine response. We get a vaccine, and it's actually introducing antigens into our body to help our body say, oh, look, there's antigens. Let's make antibodies to these antigens so that we can remember in the future, if we become infected with this type of antigen, that we know how to fight it. So if you were exposed to a germ previously, and so it's a germ your body has seen before, your B cells actually have memory and can recall the repeat invader and initiate the immune system to attack in a much quicker fashion. So this is all coordinated. All of these things are happening at the same time at any given time, and your immune system is constantly functioning to help keep your body healthy. So what happens when we use drugs to suppress these functions of the immune system? In a global sense, the biggest thing that happens is we are at risk for both infection and cancer development. So what are some of the common immunosuppressive drugs and their impact on the immune system? So the first drug I'm going to talk about is anti-lymphocyte globulins. One specific one is called anti-thymocyte globulin, or ATG. Many of you may not know what ATG is, but most of you have probably received this exactly at the time of your transplant in the operating room. And this is used to help deplete T cells. So those helpers, killers, and suppressor cells that I mentioned earlier. So what happens when you deplete T cells? You actually are at risk for reactivation of latent viruses. And what that means is there are certain viruses, excuse me, there are certain viruses that lay hibernating in our body. So what happens is we are exposed to a virus and we have a primary infection from that virus. Let's use chickenpox as an example. So you're exposed to the chickenpox virus, you get chickenpox. Now the chickenpox virus, also known as varicella zoster virus or VZV, VZV is now laying dormant or hibernating in the nervous cells of your body. So cells of your nervous system will contain bits and pieces of the virus VZV. And then when your body becomes weakened for whatever reason, or due to stress, which can also weaken your immune system, these viruses have an opportunity then to wake up from your nervous cells and leave the nervous cells and cause infection. And when it causes that secondary infection, we call that reactivation of latent viruses. And in this case, reactivation of VZV would lead to shingles. The next drug I'm going to talk about is glucocorticoids. These include drugs like prednisone, methylprednisolone, dexamethasone, and there's a whole long list of other types of glucocorticoids, but those are the most commonly used ones. This I consider the jack of all trades. It changes your white blood cell function and survival, and it depletes T cells and B cells, but T cells to a greater extent than B cells. So what happens when you affect all aspects of your immune system? You're at risk for infection for a variety of types of things. Bacteria, PJP, which is a type of fungal infection, which we'll talk about more in depth shortly, molds, viruses, and even poor wound healing in general. The next drug is azathioprine or Imuran. This decreases the number of circulating B cells and T cells. And this has been speculated to be a cause for human papillomavirus to cause more problems than it normally does. Human papillomavirus is a virus that causes warts on your hands and feet, but also genital warts and cervical cancer. Then mycophenolate mofetil, also called CellCept, also decreases your T cell and B cell production and therefore reduces your antibody production. So you are at risk for bacterial infections and CMV, which is a type of virus, cytomegalovirus, which we will also talk about a little bit more in depth shortly. Calcineurin inhibitors, these drugs include tacrolimus and cyclosporin, decrease T cell growth and leaves you at risk for viral infections. mTOR inhibitors, or rapamycin, also drugs called sirolimus and everolimus, block the response of B and T cell activation. And this leads to poor wound healing and a whole variety of respiratory infections. Belatacept, which is also called Nulogix, blocks the activation of T cells. So it blocks your immune system telling T cells to start doing their job. This in turn leads you at risk for EBV or Epstein-Barr virus, CMV, other viral infections, and PJP, which is a fungal infection. Lastly, or sorry, not lastly, almost done. Rituximab, also called Rituxan, is a monoclonal antibody that targets CD20, which is a protein expressed on B cells only. And this attacks B cells, therefore depleting B cells. So your B cells supply is decreasing, and this leads you to be at risk for bacterial, viral, and hepatitis B infection. And hepatitis B is particularly important if you've had a history of hepatitis B and then get rituximab, then that hepatitis B has an opportunity to potentially flare. Then the last two are drugs that are less commonly used in transplant patients, but we sometimes do see them being used. One is called eculizumab, also known as Soliris. This inhibits a a pathway within the immune system called complement. This is a system that recognizes features of germs on the surface and then marks them for destruction. So what happens when you inhibit complement is that you're at risk for specific category of bacteria called encapsulated bacteria. These are bacteria that basically have an envelope around them or a capsule around them. Specifically, one example would be the bacteria that causes meningitis, also called meningococcus. So people at risk for meningococcus who receive eculizumab will also oftentimes receive antibiotics to help prevent them from getting infected with those types of encapsulated bacteria. And similarly, plasmapheresis, which is not really a drug, but more so a method by which we remove complement and immunoglobulins, also known as antibodies, from your system. And this is primarily used when someone who has a high level of antibodies already present in their system prior to transplant, or if they develop antibodies leading to rejection, then we will sometimes use plasmapheresis as a means to remove those antibodies. But it leaves you at risk for encapsulated bacteria, but you can also think if you're removing antibodies, that can leave you at risk for a whole variety of infections, which I did not list, but basically viral, bacterial, anything that your body has seen previously, you are now reducing your antibodies for that and are at risk for having infection from those particular infectious organisms. So let's now talk about the infectious complications in a little bit more depth. So the sources for infectious complications, as I mentioned earlier in this talk, we have nosocomial or hospital-acquired, donor or recipient-derived, reactivation of latent infections, and community-acquired. And this picture here on the right kind of depicts how these infections, what you're at risk for, changes over time. So initially, nosocomial and donor and recipient-derived infections may be at higher prevalence at the initial time period after your transplant, but as you move forward, what you're at risk for will change. And so this slide is a similar slide, just showing that over time, what you're at risk for changes. I won't go into much depth on this slide for interest of time, but basically infections are categorized based on the time after your transplant. So post-transplant course can be divided into 3 time periods: the early period, which is 0 to 1 month, intermediate period, which is 1 to 6 months, and the late period, which is more than 6 months out. Because the full impact of immunosuppression accumulates over time, your greatest risk for infection is actually in the second period or the intermediate period, so months 1 to 6. And then any intensified immunosuppression that one may receive, for example, treatment of organ rejection, essentially resets the clock back to the initial early period. So you are continuously at risk for infection, but how at risk you are will change over time. So the first month, the 2 major causes of infection in all solid organ transplant recipients include pre-existing infections in the donor or recipient, and then infectious complications associated with the transplant surgery and hospitalization itself. The effects of immunosuppression are not yet fully obvious. There are subtle signs of it, but not fully obvious at this point. The exception to this would be for those who are receiving immunosuppression before your transplant, for example, someone who has lupus or rheumatoid arthritis, or someone who's living with an immunodeficiency, for example, HIV. Those people have a little bit of a different time course. I'm going to limit my talk to the people who are essentially not receiving immunosuppression before transplantation. So let's talk a bit about donor-derived infections. Donor-derived infections are unanticipated infections that arise from the donor organ and are activated in the recipient. Some of these infections can be latent infections, for example, like as I mentioned, that virus VZV, the chickenpox virus. If they had chickenpox a little bit before the transplant and it went undetected or unknown, and then we transplanted that organ into someone else, that person could develop a VZV-related infection soon after transplant. Some may simply be a result of bad timing. So an unappreciated active infection at the time of organ donation can result in infection in the recipient. The efficiency of transmitting the infection from donor to recipient is enhanced because of immunosuppression. And living and deceased organ donors are screened to avoid transmission of certain infections. Nonetheless, transmission of infection may still occur, albeit it is rare. Recipients of organs from donors who are known to be infected or considered at high risk for transmission of HIV, hepatitis C, hepatitis B, or COVID-19 actually require informed consent prior to transplantation. So we inform you of this high risk or of the possibility that your donor has these types of infections before we transplant you. So what about recurrent infections? So this can also be considered recipient derived infections. Recurrent infections are ones that may have been present in the recipient prior to transplantation. This includes things like hepatitis B, hepatitis C, and herpes simplex virus 1 and 2, which include infections like cold sores and genital herpes. These infections can reemerge early after transplantation. And then complications of the surgery and nosocomial infections. So infectious complications related to the surgery and hospitalization can include things like pneumonia, surgical wound infection, bloodstream infections due to the presence of catheters, or UTIs. And the organisms responsible for this are usually ones that are often found living in or on the recipient and the donor. So let's move on to the intermediate period, the 1 to 6 month period. The effect felt by immunosuppression during this time is maximal. Patients are at greatest risk for developing infections during this time. We give patients various antibiotics, antifungals, and antivirals during this period to try to prevent infections from occurring. This may delay infection, but not eliminate risk altogether, especially once those medicines have stopped. The risk of that infection then presents itself. So some of the bugs or bacteria, viruses, et cetera, that we see during this time period include PJP, which is also called Pneumocystis jirovecii pneumonia. This is a type of fungal infection, and we will talk about this momentarily. Viruses, so cytomegalovirus, Epstein-Barr virus, varicella-zoster virus, a lot of different viruses, community-acquired viruses like influenza, RSV, adenovirus, COVID-19, all of these viruses we commonly see during this time period. Latent infections, so other types of latent infections that are not viral, things like strongyloides, toxoplasmosis, Chagas disease. Other fungal infections like histoplasma, coccidiomycosis, paracoccidiomycosis, cryptococcus blastomyces, aspergillus. Mycobacterial infections are often seen, things like tuberculosis. And then we see parasitic infections during this time, like cryptosporidium and microsporidium, which can cause severe diarrheal illnesses. And then we often see UTIs. So the ones highlighted in blue on this slide are the ones I'm going to talk about in a little bit more depth because they carry with it a very high morbidity and mortality. And these are very important infections to know about and be able to recognize and advocate for yourself in case things are not seeming to go right for yourself. Then at least you can have a leg to stand on and say, I want you to check for X, Y, or Z, or am I at risk for this particular virus? So let's talk about, before we get there, let's talk about the last period, the 6 to 12 month time period, the late period. Patients are usually on stable immunosuppression and possibly even reduced amounts of immunosuppression. So their most commonly seen infections are things like pneumonia and late CMV, which we'll talk about in a minute. So let's get into those few organisms that I said I wanted to touch upon. So Pneumocystis jirovecii is the first one. So Pneumocystis jirovecii pneumonia, also known as PJP, is a potentially life-threatening fungal infection that usually involves the lungs. Less commonly infects organs outside of the lungs, but it can happen, but primarily it's a lung-related infection. We believe the transmission is airborne, so non-immunocompromised people likely carry this in their lungs and spread it in the environment, where then immunocompromised people can breathe it in, and then it sets up shop and causes infection. Steroids, belatacept, and rituximab can all increase the risk for developing PJP. mTOR inhibitors, sirolimus and everolimus, may increase one risk, but it's not entirely clear based on literature that's out there. So you may be at risk for this, but it's not 100% certain. And it's seen more often in heart and lung transplant recipients than kidney or liver transplant recipients. But that said, all transplant recipients are at risk for this infection. So here are 2 chest x-rays. The one on the right are normal lungs. You can see here that this is very clear, black, where the air in your lungs is supposed to be. The little white fluffy here in the center are just blood vessels. And then you can see the outline of your heart in the very middle here. This is your spine here. And here on the left, all this black that's supposed to represent nice air in your lungs is replaced by white.
And this is your spine here.
It's replaced by white, fluffy signs here that are indicative of PJP. So you can see here that this is all just infection, inflammation, fluid in the lungs. That's all from PJP. And here, this is just some pathology slides. The right side box here just shows these black helmet-shaped organisms. This is what PJP actually looks like under a microscope. So we aim to prevent PJP pneumonia by giving medicines to prevent it for the first 6 months after transplant. Drugs include Bactrim, atovaquone, dapsone, or pentamidine. And this infection can present with an insidious onset of shortness of breath and coughing. Fevers may or may not be present.
It's my thing.
I'm not sure who isn't muted, but if you don't
record
mute yourself,
Jesus,
that would be great. Again, if everyone's not muted, please mute yourself. So again, this can present with an insidious onset of shortness of breath and coughing, and fevers may or may not be present. And treatment usually depends on the severity of illness. Everyone gets treatment regardless of the illness, but the severity dictates what drugs you actually receive. And regardless of severity, it's a usual 3-week course of therapy, then followed by lifelong prevention. So let's move on to Epstein-Barr virus and PTLD. So PTLD is a post-transplant lymphoproliferative disorder, which is a spectrum of lymphoproliferative disorders that refers to abnormal overgrowth or cancerous growth of cells of the lymphatic system. There are 2 types of lymphatic cells involved in PTLD, T cells and B cells. The majority of PTLD comes from B cells, and the rest come from T cells. Epstein-Barr virus is the viral infection that is most commonly associated with PTLD. So PTLD risk. The greatest risk is in your first year post-transplant. More than 80% occur in the first year after transplant, and this is actually the most common cancer in pediatric transplant recipients. Your second most common cancer in adult recipients accounts for about 20% of all cancers in transplant patients. Risk factors for this include your genetics, your degree of immunosuppression, your age, so those less than 10 or greater than 60 years of age tend to be at highest risk, and the type of transplanted organ, so 20% risk for small bowel, 2 to 10% risk for heart and lung, and 1 to 5% risk for liver and or kidney. And then if you have EBV infection, that also increases your risk dramatically. So what is this correlation between EBV and PTLD? So 60 to 70% of B cell PTLDs are associated with EBV infection, whereas 10 to 40% of T cell PTLDs are associated with EBV infection. Your increased risk of PTLD is among EBV positive donors that give organs to EBV negative recipients. So we check antibodies for EBV prior to donation and prior to receiving an organ. So we know beforehand whether or not your donor is EBV exposed in the past or not exposed. If those antibodies are positive, then that tells us that they are an EBV positive donor or that they've been exposed in the past. So the highest risk is greatest for those who are EBV negative recipients. So the incidence of PTLD risk for EBV negative recipients was 24 times higher than that for EBV positive recipients. So when you have not had exposure to EBV in the past, but you get an organ from someone who has been exposed to EBV, that is the highest risk pairing. And even though that is a high risk group, we still oftentimes will pair patients in that manner because it's a good organ otherwise, and we can manage and monitor for EBV and manage PTLD. Not that it's something we expect to happen, but if it does happen, we are able to handle it if it comes on. So how can we detect or prevent PTLD? So it can be detected early by monitoring EBV blood levels. So we see here a graph. The y-axis here, the vertical axis, is your EBV level in your blood, and the x-axis here is your time over months to years. So here we see you have your initial infection early in life, probably usually as a young child or as a teenager. EBV's initial primary infection is mono. So when people have mono, they've been exposed to EBV in the past. So you have your primary infection, you have your symptoms of mono, that gets better. And then for years, this lays dormant in your lymphatic cells. So in your spleen and your lymph nodes, et cetera, this virus just lays hibernating in these areas. And then you get a transplant and you get immunosuppressed. And here we now monitor EBV. Most programs do this weekly. There's different protocols for different institutions, but we monitor the EBV level and we might see some highs or lows, some little blips as we call them, nothing too crazy. But then all of a sudden we may see a steady rise. And then here you may start to have some vague symptoms. This is when we start to worry, oh, is PTLD coming? We may start to implement some of the therapies or measures we take to help prevent PTLD from coming on in this early time period when we're detecting a rise in your EBV. But if we can't prevent it, it may peak, you get treatment for your PTLD and things get better and you go back to having these usual blips that we normally see in people. So PTLD diagnosis. Disease presentation is often nonspecific: fevers, weight loss, fatigue, enlarged lymph nodes, compression of surrounding organs due to mass development, and this all delays diagnosis. But diagnosis is usually made with imaging and a biopsy, and it presents on imaging as a new mass or enlarged lymph nodes. PTLD may involve the transplanted organ in about 50% of the cases and can be detected by early monitoring of EBV levels, as I discussed shortly ago. PTLD treatment usually involves reduction of immunosuppression, chemotherapy, antivirals if EBV has been proven, radiation therapy. The mortality is 30 to 60%, but we generally have good outcomes. It is important to seek medical care when things don't quite feel right. You should advocate for yourself. These things generally present nonspecific, as I mentioned, and so it's really important that you are just in tune with your body and are aware when something doesn't feel right. So let's move on to cytomegalovirus, or CMV. So this is a globally widespread virus that becomes latent after initial infection. Many people have been exposed to CMV at some point in their life before transplantation or organ donation. Some show signs of infection at initial exposure and others do not. It's speculated that anywhere between 40 to 60% of the population has been exposed at some point in their lifetime. This becomes a latent virus after primary infection and can reactivate and become active infection or disease at a later time point when your immune system is weakened. CMV infection or disease is associated with a risk of organ failure and patient death. CMV infection is defined as the presence of CMV actively growing, or also called replicating, in the blood, regardless of whether or not signs or symptoms are present. CMV disease is defined as the presence of CMV actively replicating in the blood, along with other clinical signs and symptoms. And disease can be further categorized into syndrome and tissue invasive disease. CMV syndrome is active CMV replication with symptoms, but without any organs being affected. Whereas tissue invasive CMV disease is active CMV replication with symptoms and with organs being affected. Organs that can be affected include your colon, small bowel, liver, pancreas, kidneys, lungs, eyes, and central nervous system. So who's at risk? Primary risk factor for CMV infection or disease is the CMV serostatus of your donor-recipient pair. So this is much like the EBV that we were talking about moments ago. CMV is very similar. So your serostatus is your presence or absence of antibodies against CMV. If present, it means that the person has been exposed to CMV previously. Serostatus can either be positive, meaning antibodies are present, or negative, meaning antibodies are absent. And the pairs can be donor positive, recipient negative, which is the highest risk group, donor positive, recipient positive, donor negative, recipient positive, and donor negative, recipient negative. So CMV disease presentation really depends on which organ is being involved. One of the most common presentations, especially in kidney transplant recipients, is gastrointestinal disease. And this usually presents with diarrhea, nausea, vomiting, difficulty swallowing, abdominal pain, etc. If your liver is infected, that can cause a hepatitis, which you may see jaundice or abdominal pain. Pancreatitis, or your pancreas being infected, will result in abdominal pain. You can have a pneumonitis, or your lungs being infected, and that would result in cough, shortness of breath, fevers. You can have a meningoencephalitis, which is your central nervous system. That can cause headache, stiff neck, confusion or altered behaviors, or even paralysis. And then you can have retinitis, which is your eyes, and this would cause changes in your vision. Or you can have nephritis, which are your kidneys, which would cause change in kidney function, or you might notice decreased urine output or even blood in the urine. So with CMV, prevention is key. So prevention strategies include universal prophylaxis or preemptive therapy. Universal prophylaxis is the administration of antiviral medications to high-risk patients beginning within 10 days of transplant and continuing for 3 to 6 months. The drugs used here are either valganciclovir or Valcyte, or a drug called letermovir. There's also preemptive therapy, which includes monitoring for CMV replication in the blood at regular intervals, usually weekly. And then valganciclovir is started when viral replication is detected at a particular threshold. You can also have a preventative program called surveillance after prophylaxis, which is essentially the combination of the above two types of prophylactic or preemptive therapies. This is a less commonly used preventative method, however. So the 2018 International Consensus Guidelines on the Management of CMV and Solid Organ Transplantation tells us that we should use universal prophylaxis for the D+R+, D-R+, and D+R- groups. So again, valganciclovir is started in the immediate post-transplant period, and for D+R-, they receive this drug for 6 months. For the others, they receive it for 3 months. And then the guidelines also tell us to use preemptive therapy for the lowest risk group, D-R-, where we monitor for CMV replication weekly for 3 months following transplantation. These patients instead receive medicines to prevent HSV and VZV only, valacyclovir or acyclovir. I should mention that valganciclovir, which is used to prevent CMV, also helps prevent HSV and VZV. And then if you are treated for rejection, prophylaxis is often restarted. So these viruses have another impact on the immune system. Specifically, CMV serves as a means by which someone can develop other opportunistic infections by further immunosuppressing the patient. There are other viruses that do this, which I've listed here, but CMV is the most commonly seen one. So there are direct effects from the virus and indirect effects from the virus. Direct effects include virus-specific clinical syndromes, and indirect effects include immunosuppression and predisposition to other infections, organ rejection, and oncogenesis, which is essentially cell proliferation or overgrowth leading to cancer. So the conclusions of this study are that the net state of immunosuppression is a conceptual assessment of the factors contributing to the risk of infection in an immunosuppressed person. The immune system is complex and can be variably impacted by the drugs we use to prevent rejection of transplanted organs. The ways in which we suppress the immune system impacts what infections we can see post-transplant. And PJP, CMV, and EBV are commonly encountered infections post-transplant that carry high morbidity and mortality. And these viruses can impact the immune system further by leading to more infections, organ rejection, or even cancer. These are my references. And I leave you with a quote: take care of your body. It's the only place you have to live in. I thank you for your attention. My email is here on the screen if you have questions, but I'm going to stop sharing my screen and address some of the questions in the chat.
Dr. Seema, that was great. A lot of information for everybody. And I can't get my chat to open for some reason. Oh, here we go. And I will apologize now for any mispronunciation I have on any of the information in the chat. So we keep forgetting. I do apologize. We will look into closed captioning to see if how to get that, make that available on our presentations. And the slides will be available on our website under this date, probably next week. And Gwen asks, my labs come back consistently with an abnormal white cell count even before transplant. Is that hereditary, lifestyle? What could cause that?
Yeah, so that's usually hereditary. It's usually a genetic condition that some people have abnormal white blood cell counts, either low or high. And there's nothing to do about it. Sometimes people who have on the low end, they may get support by medications to help boost their white blood cell count. But generally speaking, if it's you at baseline, and we take that into consideration when we determine what infections you're at risk for. But there's really nothing you can do. There's nothing that you are doing that's contributing to that.
What effect does Invarsus have on the immune system and the risks? And then someone said also known as Tacro. And then someone said Invarus is the time-release form of tacrolimus. So I'm not sure.
Yes. So tacrolimus we talked about. So tacrolimus does affect your ability to fight off viral infections and bacterial infections. So you are at risk. It does deplete portions of the immune system that places you at risk for those infections. But it is there in the table in my slides, there is a specific line for tacrolimus.
I remember seeing that. And someone said they didn't see Myfortic listed. What are the side effects? How commonly prescribed?
So Myfortic is essentially the same thing as mycophenolate mofetil, which is also Cellcept. There's just two brand names, Myfortic and Cellcept. I only included Cellcept. I apologize, but we discussed that as well.
I'm sorry. Someone then did actually say that too. And then someone asked a question and you had just answered it. And let's see. Why isn't pancreas included in these numbers?
So pancreas transplants are done far less frequently than the other organs. Usually if a pancreas is done, oftentimes a kidney is done with it. So they get lumped into the kidney numbers usually, not the pancreas numbers. But that's why we just don't have enough numbers to actually formulate appropriate percentages and risks, because pancreas is just not done often.
Thank you. Percentage of overall transplant patients that acquire EBV or PTLD?
Yeah, so that's a really good question. That, as I said, it's 20% of all cancers, that transplant recipients get. So it's a pretty high number. The longer you live, the more likelihood there is for developing cancer. And if 20% of that chance is PTLD, that's a pretty great number. We don't have actual specific X number of people are going to get PTLD, because the risk is so complex. And as I showed you, it depends on your age, your genetics, the type of organ you have, your EBV serostatus. All these things play a factor into whether or not you develop PTLD. So it's so complex that we can't really tell you for sure, if you have certain things, will you get PTLD or will you not get PTLD? So it's really hard to know the exact number.
Thank you. From Lauren, I am in remission from multiple myeloma, which caused kidney failure in 2017. I had a kidney transplant in January 2021. Since October 2022, I've had diverticulitis and colitis 3 times, followed by C. diff. Treated successfully so far with standard antibiotic regimen each time. After first time, the doctor took me off mycophenolate. I'm only on 2 milligrams of sirolimus and 5 milligrams of prednisone now. Do you see diverticulitis, colitis much in other transplant patients?
Yeah, it's actually a very common problem. That's a type of, we consider it a community acquired infection, even though you're not really contracting it from somewhere. It's something that's happening within your body leading to infection. It is something that we still consider something that we see late out from transplant. So since you had your transplant in 2021, you were beyond the 12-month period, which makes sense as to why in 2022, you started seeing some of these community acquired type of infections, or things that we would see in the general population even happen in you. So it is a common thing to see, however.
And someone asked a question and then realized you already answered it. Thank you for the great presentation. Wow, very complicated. Even greater, they have even greater respect for the transplant surgeons now. Is it common to get a CMV infection many years after a transplant?
So the late CMV that we will see will often happen after 6 to 12 months, but generally speaking, it is not common after you've past that time point. And if you're on stable or reduced immune suppression, the chances of you having CMV go down with time. But if you get treated for rejection, then that risk starts all over again, and then you're at high risk for developing CMV. And so if you have rejection late, far out from transplant, then there is the possibility that you could be at risk for it. But otherwise, if you are stable, the further you go, the less likely you are to have CMV complications.
Thank you for all the information. BKV, is there anything I can do to control it? Can I take vitamin C to increase my immune system?
So vitamin C is definitely great to take. But I don't believe there is any literature out there on saying that it would help control BK virus. BK virus is has a direct relationship to how immunosuppressed you are. So the more immunosuppressed you are, the more likely you are to have BK virus if you're a kidney transplant patient. So the way we address BK virus is we back off on your immune suppression. We reduce it as low. We go back as far as we can without causing rejection. And that's how we control BK virus. By reducing your immune suppression, we're allowing your own immunity to kick in and try and fight it. But we don't have any therapies actually directed at BK virus. So taking vitamin C can certainly help your immune system, but it's truly directly related to the immunosuppressive drugs you're receiving. And, it may just be a matter of trying to balance rejection with BK virus. And that's like walking a tightrope. It's very challenging.
Thank you. Do you have a list of suggested vaccination for immunosuppressed individual? RSV, which ones? Shingles, hepatitis A or B, pneumonia, which ones, how often, HPV, etc.
Yeah, so that could be a whole talk in and of itself. So I can,
Oh,
what I
good.
can
We'll
do is,
book you. We'll book you for another month.
what I can do is I'm happy to give another talk on that particular topic, or I can also provide you with a little table of the vaccines that one needs after transplant. And when I send you my slides, Michelle, I can send that over to you as well.
Perfect.
That would be great. I am going to copy that so I remember. Okay, good questions. Great info. Certainly explains why you're in so many medicines. You mentioned something about warts within discussing viral infections. Are warts more common in immunosuppressed people? I know it's a simple question, so sorry.
No need to apologize. It's a great question. Warts are more common in immunosuppressed people. And there is a talk that I actually give on cancer after transplant. And I've given it to this group before. And in that talk, I do talk about human papillomavirus and how there's actually a higher risk of not only warts, but cervical cancer as a result of human papillomavirus in transplant recipients. So it is more commonly seen.
Thank you. Are there guidelines in reducing immunosuppression for 10 years post-transplant?
I believe that there are. As infectious disease, I don't directly manage the immunosuppression. It's either up to your transplant provider, so like your transplant nephrologist, transplant hepatologist, whoever, who makes that decision. And we make that decision with them when we start facing infectious complications. But I do believe that 10 years out, you should be on a reduced amount, especially if you haven't had any bouts of rejection or anything like that.
What an amazing presentation. So thank you, of course, for helping Dr. Seema explain all these terms in plain speak. Laura had trouble with BKV. Another thank you for the pancreas answer. Excellent presentation. Makes me feel even more thankful for my kidney transplant team, keeping them healthy, and it's truly a complex treatment. Relationship with tacrolimus and bullous
Pemphigoid.
pemphigoid.
Yeah, bullous
Thank God
pemphigoid.
you know how to say all these words, Dr. Seema.
I don't know the exact relationship off the top of my head. I can try and look into that and also include that information when I send you my slides.
Okay, that's great. Thank you for all the information. Immune system so complex. Glad to have a better. I'm 70 and on my second kidney. I was just put on acitretin because of increasing skin cancer. What is acitretin and its effects? I'm probably not saying that right. ACITRETIN.
So that's also something I would have to look up. I believe it's just a type of topical agent, but I would have to look that up and let you know. I don't know the answer to that off the top of my head.
Okay, thank you. Did you say the more you live, the more your chances increase for getting cancer?
Yeah, I mean, that's true with or without a transplanted organ.
Everybody. Mhm.
Everybody has that risk, right? I think just immunosuppression suppresses your immune system from keeping in check cells that are abnormally growing. And as a result, when you have abnormal cell growth, you then are at higher risk of developing cancer. So we may see cancer a little bit at a higher frequency in patients who are transplanted, but regardless of that, the longer you live, the more likely it is that you would develop a cancer.
Thank you. How do vaccines work in an immunosuppressed person? We're going to be wrapping this up here in a minute.
So vaccines work, but less effectively because of all the medicines that you receive, which is why the COVID vaccine, for example, is effective, but far less effective as compared to the general population. So they still work, they still function the same exact way as it would in a normal individual or a non-immunosuppressed individual, but that efficacy or the ability to produce a robust antibody response to the vaccine is decreased because of the immunosuppressive drugs you receive.
Thank you, Stephen. Stephen is so bright. Thanks for a phenomenal extension of the invaluable learning from your February 22 presentation. We're incredibly fortunate to be recipients of your knowledge. So thank you very much. Marty and I feel the same way.
Thank you.
If my immune system is suppressed from my lung transplant, would a shingles and RSV vaccine even be effective then?
Yes, as I just said, it is effective. It just may not be like these are, numbers I'm using. These are not specific to the vaccines you just mentioned. But if a vaccine happens to be 100% effective in the general population, it may be 75% effective in an immunosuppressed individual. So it's still effective, but just at a reduced amount.
Thank you. I had PCP and CMV at 10 months after my liver transplant. I'm now 14 years out. Are these viruses in my system? And what's my risk of getting them again?
So CMV and PCP are both CMV is a virus, PCP is a fungus. Once they've been in you, they do remain in you. So as long as you are following your transplant team's recommendations as to what medicines to take or how frequently to be monitoring yourself with blood work, you will be fine. You are at risk for having them come back, but that risk is minimized by taking medicines and or following closely with your transplant team.
Thank you. My kidneys failed 2011, 7 years on dialysis, transplanted in 2018. I was diagnosed with good pasture syndrome that destroyed my kidneys. What are my risks for a reoccurrence?
Reoccurrence of good pasture syndrome. I don't know what the numbers are for the recurrence of good pasture syndrome after transplantation. I would have to look into that.
What is considered reduced amount of immunosuppression?
So reduced amount is different for everybody, and that is the lowest amount of immunosuppression that one can receive while balancing prevention of rejection. So you don't want to drop it so far that you end up rejecting your organ, but instead you drop it just enough so that you're balancing again between saving your organ from rejection, but decreasing your chances of having infection and cancer develop.
Thank you. And yes, Dr. Seema did say the longer you're out, the greater chance you have of getting cancer, but that's true for everyone. Awesome meeting. What about EBV?
Yeah, I mean, I had several slides on EBV and PTLD. PTLD is the direct cause of EBV. So I had several slides about EBV there. So,
and the slides will be available. You'll be able to relook at all of this on the website. And the gentleman, Neil, that got good pasture. He worked in the industrial field for 35 years and kind of given a reason maybe what caused the liver failure. Can't say thank you enough. Marty and I are getting thank yous, but the thank yous are to Dr. Seema. She had to get up earlier today. She is in Colorado. Excellent speaker presentation. How can I do when mouth kissing with a new romantic partner? I am 26 years old, male with a kidney transplant.
So that's actually a question we get pretty frequently from younger transplant recipients. And we always say, live your life to the fullest, but also be cautious in the sense that if your partner is sick or coming down with a cold, avoid kissing on the mouth, avoid that exchange altogether. Those are it's just common sense things. Try not to put yourself at risk, but you should still live your life to the fullest. And that is the whole point of getting a transplant, is so that you can live your life to the fullest. So we don't certainly want to limit that, but we also want you to use common sense and to take precautions when it's necessary to.
Thank you. Lots of information. Thank you for the time from Chris. As always, excellent. So much information. You will get a recording you will get the link to the YouTube recording in about a week. So you will be able to revisit some of this again if you missed a part or want to clarify something. You will have access to the slides on our website, triomaryland.org. So thank you, Dr. Seema.
Thank you.
And I also would like to thank you, Doctor. You're always so helpful and cheerful when you get on the phone with us in the morning. And I really want to thank you for your time. We wanted to thank everyone that attended today. We love seeing everyone's face. For all of you who would like to know what's going on the rest of the year, please go to our website and check out our events pages. We do have a full agenda from now to the end of January. And check out our website in general, www.triomaryland.org. All of our past meetings are posted to our YouTube channel for your convenience. And watch out for the sun and the heat, and still plan to try to finish out a great summer this year, guys. So we want to thank everyone.
It's great to see a lot of faces. And it
Thank
was great
you.
seeing you again, Dr. Seema.
Thank you. It was great seeing you too.